All right, welcome everyone. My name is Justin Carlson, and I'm one of the moderators for our session today, joined by my colleague Pascal Cassan. Welcome, Pascal.
Yeah. Thank you, Justin. I'm Pascal Cassan. I'm head of the Global First Aid Representative of the International Federation of Red Cross and Red Crescent.
Great. So we're really happy to be joined by a fantastic panel of experts today. I'm going to give each of them an introduction so that everyone in the audience is familiar with the depth and breadth of talent that we have here with us today. So we have three panelists who are with us today: Vera Bora, Nisi Singletary, and David Zeidman. And just to share a little bit with everyone here, kind of the experience that everyone brings to the table. I wanted to start first with Vera. So she's an evidence-based practice methodologist at the Center for Evidence-Based Practice of the Belgian Red Cross. She's been involved in the development of several first aid guidelines, not only for Belgium, but also for Sub-Saharan Africa and Nepal. She's also developed several systematic reviews relevant to first aid, but also to humanitarian aid and blood transfusions. In addition, she's also coordinator of the Cochrane First Aid Field and a member of the ILCOR First Aid Task Force. In her presentation, she'll explain a little bit of how to use limited evidence in first aid guideline development. We're also joined by Nisi Singletary. Nisi is a professor of emergency medicine at the University of Virginia and the chair of the ILCOR First Aid Task Force. Following graduation from Eastern Virginia Medical School, she completed a residency in emergency medicine at Brooke Army Medical Center in San Antonio, Texas. A 30-year member of the National Ski Patrol, Dr. Singletary has been actively involved in the development of the outdoor emergency care and outdoor first care courses and textbooks. She's a member of the ILCOR Scientific Advisory Committee, a member of the White House's Stop the Bleed Program Education Consortium, and serves as the volunteer chairperson of the American Red Cross Scientific Advisory Council. Last but certainly not least, we're joined by David Zeidman. David Zeidman was a consultant anesthetist at the Hammersmith Hospital in London from 1980 until he retired from the NHS in 2009. He's now a senior HEMS consultant with Thames Valley Air Ambulance. In 2020, he was awarded the esteemed fellowship of the Royal College of Physicians and received the gold medal from the Royal College of Anesthetists in recognition of his service to anesthesia and medicine. David was a founding member of the Resuscitation Council of the United Kingdom and the European Resuscitation Council. He was chair of the European Resuscitation Council from 2003 to 2008. David was a founding member of the of the International Liaison Committee on Resuscitation, ILCOR, co-chaired the Pediatric Task Force from 2000 to 2005. In 2010, he co-chaired the ILCOR Consensus on Science meeting, and since 2010, he has been the co-chair of the ILCOR First Aid Task Force. In 2010, the American Heart Association named David a resuscitation great for his international contribution to resuscitation medicine. So as you can see, we have a fantastic panel of experts today who've done pretty much everything that could be done in medicine. And so I just want to first start by saying thank you to each of the three of you for being here, for taking your time and sharing your knowledge with us. And I wanted to first start, Vera, with you and give you an opportunity to kind of lay the groundwork, talk a little bit about evidence-based medicine to get us ready, and then we'll go on to Nisi and then David. But before we get to your presentation, we wanted to put up a poll for the audience to kind of see where folks' understanding of evidence-based medicine is. So Francis, if you can put up the first poll right now, we'll put that up and we'll let the audience answer our first question here. All right, so we've got the results of our poll here. Scientific evidence, 86%. Preference and interest of the target audience, 19%. Knowledge and experience of experts, 63%. The knowledge of my grandmother, 5%. So some evidence-based grandmothers out there, which is fantastic. And also, so thank you to the 65 individuals who participated in the poll. So with that, I want to turn it over to Veer to share a little bit over the next few minutes. And then we'll engage in a little bit of discussion around that. Vera, I'm going to turn it over to you.
Okay, thank you, Justin. Thank you for the kind introduction. And thank you everyone for answering the poll question. That was really interesting. the correct answer will be given during the presentation. So I will just share my screen now. Yes, let's see. Okay, so I hope everybody can see my screen now.
Yeah, absolutely.
Okay, thank you. So guideline development in developing first aid guidelines and how to handle the use of limited evidence. Because unfortunately, in the field of first aid, there is not that much high quality evidence found. So how can we work through this? Let's see. Okay, so how do we go from evidence to guidelines? This is just a flowchart summing up the process of guideline development. It all starts with the prioritization of research questions. For each research question, a PICO question is formulated, search strategies are developed and searched in databases. We select the evidence and extract and synthesize data. Of course, quality assessment is performed of the included studies and levels of evidence are assigned. And finally, recommendations can be formulated based on the evidence. These are all steps that are performed by the ILCOR First Aid Task Force. And the final product are co-stars, so consensus on science and treatment recommendations. But then these recommendations have to be contextualized and implemented and evaluated, and that is the task of the guideline developing groups, such as the ERC or the American Heart Association, American Red Cross, or even the International Federation of Red Cross and Red Crescent Societies. And the final product is an evidence-based guideline. But in looking for evidence, what if you find only limited evidence? And by limited, I mean both in quality and quantity. And unfortunately, that is often the case in first aid field. But then you need to balance the certainty of evidence and the preferences, the benefits, the harms, the risks, and the costs. So it's not only the evidence, but you have to see if it's also available for the target group. What are the benefits of the intervention? Are there high costs? It all plays a role in the recommendation you make. If you don't find any evidence, then you can look for indirect evidence. So you take a step back and broaden maybe your PICO question or your study types. You look for, adjust your search strategy to look for evidence that is indirect. An example we did for the compression wrapping for closed extremity joint injuries. We looked for the use of compression wrapping in those injuries in a pre-hospital setting. But no studies were available, so we had to include indirect evidence, so studies that were performed in a hospital setting. Then, if you still can't find any evidence, then you can formulate good practice points. It can happen that you find conflicting evidence. If that is the case, so conflicting evidence, we mean studies that are contradicting each other. You can look for an explanation of the conflicting evidence. Sometimes it's clear that one of the studies has a high risk of bias and that can explain the conflicting evidence. And then you can leave out this study and just focus on the other studies. Another thing you can do is check the outcomes because it can be conflicting for one outcome, but not necessarily all the outcomes, or even if it's a critical outcome or just an important outcome, that is also very important in deciding what to do with the conflicting evidence. If you cannot find an explanation for the conflicting evidence, then you need to treat it as if no evidence was found and maybe formulate good practice points. Sometimes evidence and opinion are conflicting, so maybe the experts do not agree with what the evidence says. Then you need to check the context. Is the evidence in the same context as the experts are thinking? And if that is the case, you can adapt your recommendations to the context. and then you can balance the certainty, the preferences, the benefits, harms, and risks, as I mentioned before. Let's see. Is it not moving? Okay. So the take-home message from all of this, if you watch my presentation, my pre-recorded presentation, there is a full explanation of all these types with examples in there. But the take-home message really is that guideline development is more than evidence alone. So the poll question asked whether guidelines should be based on evidence or the preferences of the target group or what experts say. It was indicated that multiple answers were possible. We couldn't see whether people indicated multiple answers, but it's a combination of all of these. So at the basis, there is the best available scientific evidence, but you always have to keep in mind the preferences and the available resources of the target group and the practical experience and expertise of experts in the fields. Okay, so that was a short summary of my presentation that was pre-recorded. I don't know if there are any questions from the audience or the moderators. I will be happy to answer them.
Great. Well, thank you, Vera. Appreciate it, and appreciate you setting the stage for what we're going to talk about. One of the questions that came up in the chat was, so how does grade fit into all this? And maybe if you can give a quick little bit of grade and how that builds into this process.
Well, it's in my first slide, I showed the process of guideline development, and it's important to rate all studies on their quality to see if there was any risk of bias or any study limitations. And grade is a tool to rate the overall certainty of your evidence. So you take everything together, all your studies together, and then you look at was there a high risk of study bias? Is there indirectness? So those are points to downgrade for. Is there inconsistency? Is there a publication bias? So those are all things that grade assesses, and you can downgrade your certainty. So if everything is great, if the study is very well performed, there is no risk of study bias, you have direct evidence and no inconsistency, all of that, then you can have high certainty evidence, and you can maybe, depending on also the preferences and the harms, the benefits, as I mentioned, you can make a strong recommendation. If it's not the case, you have low certainty or very low certainty evidence, your recommendation may more be a weak recommendation. But that is where grade fits in the whole process. It makes the translation from the evidence to, or the certainty of the evidence to the strength of the recommendation.
Thank you. Thank you very.
Go ahead, Pascal.
Please, Jensen. No, okay. Yes, very. In fact, in this consensus on science, we are working for the global level. How you can include a remote area with limited aspect of the possibility of first aider to do something with the recommendation we are giving. How you can include this adaptation to the remote area according with the evidence based.
I'm sorry, can you repeat? I didn't quite get it.
We are working at the global level. In fact, the recommendation are for, in fact, perhaps we can say developed country, how to adapt to remote area the consensus on science according the evidence based.
Yeah, okay, that is why you need the experts and the target population that you keep in mind. So those are the two other pillars next to the evidence. That is really important to keep in mind, because in some contexts, an example I think is from the review of dental avulsion, the storage of an avulsed tooth, where we found evidence that was in favor of rice water. So based on the evidence, we could recommend rice water to store in a Volstoot. But after discussion, we decided that rice water takes too long. Well, you need to prepare rice water because rice water is just boiling rice, and the water that is left after boiling is the rice water, but it just takes time to get rice water, and that may not be feasible in a first aid setting as well. Although it would be feasible maybe for developed countries because they use it a lot and they have it easily available. So those are all things that you need to take into account, and that makes that sometimes you have evidence in favor of an intervention, but you will not recommend it because it's not feasible in certain settings.
And Vera, I think that's a really good point that you made, right? It would be wonderful if we had large randomized trials comparing intervention A to intervention B. We have almost none of those in first aid. And so just as you mentioned, a lot of things get downgraded based on grade. They're indirect evidence. They're pulled from some other place. Yet at the end of the day, we need to make some statement to address the problem as best we can. And one of the things that might be a little bit different for folks, or that they may not have seen before, are what are called good practice statements. Do you mind taking just a minute or two and explaining what those are and how we got to those, or how someone might get to those?
Well, a good practice statement, the name says it's something that is maybe common sense, or is something of good practice. But the important thing of a good practice point is that there is consensus about a good practice point. So it's not just one person that can decide we will do it like that. And it should only be used if no evidence is available, or if the evidence is uncertain. Then you may decide to formulate a good practice point. But as said, the importance there is consensus in the expert panel about the good practice points.
Yeah. Well, thank you. Appreciate you laying that out there for us. And now I'm going to turn it over to David and Pascal, excuse me, Nisi and Pascal.
Lady first.
Yes.
I did want to put up another question for the audience ahead of this talk to see kind of where we are with a concept called TACO. And so there will be a question. Francis should be putting up a question right now. And we'll get some response to that. And that is, what does a TACO have to do with cooling for heat stroke? And hopefully over the next few minutes, we'll be able to answer that question. But I want to see where folks are right now with that. We'll give it another couple seconds here for folks to answer.
Waiting for.
Yep. All right, Francis, do we have answers? Well, I'll tell you what, while Francis is putting all that together, Nisi, if you want to go ahead and get started with your part of the medical piece of first aid.
Yeah, absolutely. Thank you, Justin. And the TACO question will come up at the very end once again, because I actually have a slide of a TACO for all of us. So medical first aid, I just wanted to, in the short time that we have today, go ahead and show you some of the things that we talked about, or I talked about in my presentation that was pre-recorded. The topics that you see listed here are all medical emergencies for which we have treatment recommendations on for first aid. And the topics that are in black font are ones that I did not cover because they were scoping reviews with no change in treatment results and no indication for a new systematic review, or there was nothing new in an evidence update to also trigger a systematic review. So I talked about methods of glucose administration for hypoglycemia, which is looking at the routes of glucose administration, and which ended up basically saying in the treatment recommendation that we recommend the use of an oral route for glucose as compared to a buccal delivery system, such as using glucose gel in the buccal sac. And we also recommended that for children that are uncooperative with an oral route, that you can use a sublingual route, such as a teaspoon of a wet sugar paste under the tongue. For exertional hyperthermia, I'm going to talk a little bit more about that in just a moment. Stroke recognition was an update of a previous systematic review in 2015. And the recommendations are essentially unchanged. It's that we do recommend the use of a stroke recognition scale or system for first aiders to help them recognize stroke, and that the outcomes that by using one of these stroke scales is a faster time from the onset of the symptoms to treatment, so sort of a time of symptom onset to the door or to treatment, definitive treatment. So they are very helpful, and the recommendations are divided up into scales that either include glucose measurement, if you have that available, which many people do now, unfortunately, especially older people who are at risk for stroke, or if there is no glucose measurement capability. There was a review on supplemental oxygen use for acute suspected stroke, which showed no benefit for multiple different outcomes with the use of oxygen between 2 and 45 liters per minute. So we recommend against the use of supplementary oxygen for acute suspected stroke. An updated review on use of aspirin in the first aid setting for chest pain found no new literature, and has basically the same recommendation for the early use of aspirin in chest pain. Previously, the population was if a myocardial infarction is suspected. Now it's open to people who have non-traumatic chest pain. And that change was made because of the realization that first aid providers cannot diagnose myocardial infarction, cannot sometimes recognize myocardial infarction as well. And on top of that, it's proven benefit and survival with early use of aspirin for chest pain from myocardial infarction, and very, very low incidence of any type of adverse reactions as long as you're not allergic to it. So that recommendation stands, but is now expanded to individuals with chest pain of a medical cause, so non-traumatic chest pain. And then recovery position, I will talk a little bit more about in just a moment. So exertional hyperthermia and heat stroke, that was the hot topic, so to speak, for this last year because of so many people having problems with heat waves and heat stroke, and knowing that there were the Summer Olympics coming up this last year that were postponed because of COVID, and an area where there was problems with heat stroke a year prior. So this review looked at 12 different methods of cooling and found to not too much surprise that the most rapid cooling rate was through full body immersion in water, from the neck down, immersion in water. And the thing that was also surprising was that it didn't have to be ice cold water, even temperate water was very beneficial. The other surprising thing about this was that active cooling by water immersion cooled much faster than many other types of active cooling as well as passive cooling. And I'm just going to move this on to the next slide, which shows a very nice graph with the weighted mean cooling rates by cooling technique. So it's probably a little bit small to read the font at the bottom, but all the way to the left, the tallest bar is going to be the fastest rate of cooling. And then as you go to the right, it becomes slower and slower. And the third from the right here, if my cursor shows up on this slide, is passive cooling. So all the way to the left is ice water. And then the next fastest was temperate water, then cold water, colder water, commercial ice packs to the neck and body, over the body, followed by showering, ice sheets, immersing the hands and feet in cold water, cooling vest and jackets, cold IV fluids, fanning, passive cooling, hand cooling, and all to the right is surprisingly evaporative cooling. which is something that many people have been taught over the years is one of the fastest ways to cool somebody. So that was a surprise. And then the final recommendation was that we recommend that a first aid provider use whatever active technique you have to cool on hand available to use that will cool the fastest. So while you can kind of look at that chart, unfortunately, we can't give you a rank order list out of this because the confidence intervals overlap on the different techniques. But we know that water immersion is the fastest and that in general, the trend towards colder is better. Okay, so moving on, recovery position was another topic that I discussed that's very important because we changed the wording and did a scoping review. The wording for recovery position in the past was looking at persons who were unresponsive and breathing normally, and the recommendation was to put them into a lateral recumbent or sideline recovery position. We changed the wording, tweaked that wording a little bit for the population because of concerns that there could be missed cardiac arrest in some individuals in a recovery position or respiratory arrest. So the wording now is adults and children who have diminished level of consciousness, but who are not in need of CPR or rescue breathing. And the diminished level of consciousness was for a medical reason. So it takes out trauma. And the scoping review identified a lot of literature that essentially supports the lateral sideline recumbent position. But in discussion with the task force, there's still a lot of concern about certain populations, such as opioid overdose, where if they are placed on their side, that they may actually be hypoventilating and hypoxic, and there could potentially be a respiratory or cardiopulmonary arrest that could be missed. So we are going to be working with the Basic Life Support Task Force in creating a reworded new PCOST and also try to focus especially on those individuals who may be identified as having a opioid overdose. And I know that's not a major problem in Europe, most of Europe, but in North America, it's a huge problem and needs to be addressed. So those are the topics. And Justin, I'm going to let you go back. I did have, if we have a minute, those are the upcoming reviews for 2020 that we are working on, just to give everybody a sneak peek, which was first aid for jellyfish stings, rehydration following exercise-induced dehydration, tourniquet use in children, cooling of burns for 20 minutes or an alternative duration, tick removal techniques, open chest wound dressings, cryotherapy for epistaxis, and we did an evidence update on pressure immobilization bandaging for snake bites. And that's it. So.
Thank you very much. It's fantastic. So thank you, Nisi, for this very synthetic and interesting presentation, and also for the incredible work you have done in the Hillcore First Aid Task Force with David, because you have done so many things. I'm really impressed. We have some answer concerning our question concerning the cooling, and it's interesting because 10% said never eat one before running a marathon. 6% the hot sauce is associated with head injury. I have no idea, 42%, and probably it's nearly 40% that it said it's great way to cool a person with a head stroke in the first aid setting. So very not bad, but not perfect.
Not bad. So let me tell you about tacos. And tacos, I love tacos. They're very popular in the United States, and we probably eat tacos once a week or every other week. But this type of a taco stands for TARP assisted cooling by oscillation. And this is a technique that first aid providers can use for cooling of heat stroke and exertional hyperthermia. So we talked about in this slide here, water immersion being great. And then of course, that can be ice, water, or temperate water. But how can you do that if you're in a first aid setting? Most people don't carry tubs with them. Although if you have a little inflatable kiddie pool, you can use that, or you can use a garden hose or a shower. But one other technique you can use is the taco method. And the taco method looks like this. And it's where you take a tarp, put your victim on the tarp, and then pick them up, pour water such as from whatever water source you have, even if you have a cooler with some melted ice water and that slurry, you can pour that in there. And then the people on one side lift up and then release while the people on the other side lift up, and you oscillate and circulate the water around to help them cool. So that is a taco method, and it actually is a fairly slick and easy way of trying to cool somebody with heat stroke.
Oh, great, very interesting, for sure. And again, because I asked the same question to Veri for remote area, what could be the best cooling method when we have no possibility of bath, no possibility of shower?
Yeah, so that's what I was kind of alluding to, that you could use a kiddie pool if you know you're going to have an event such as a bike race on a very hot during a heat wave, a marathon, something like that, and you've got first aid stations. You can use children's pools, little what we call kiddie pools in the United States, but they're children's inflatable pools. Take them to the tent and set it up, and then you put the water in it ahead of time, and you have it ready to go. So that's one of the ways, along with a garden hose, a shower. If you have a stream nearby, you can put them in it. The taco method is great as well.
Great,
that's it.
Great, good. As you are the chair of the co-chair of the first task force, I have another question. What topic reviewed by the first task force do you think has the most surprising findings, and why?
Well, actually, I think it would probably be the cooling for heat stroke. There were some problems with the entire review in that it did not include children. So there were no children, and this is all just in adults. It also was a review that ended up depending upon a lot of studies in volunteers that were healthy, normal people who were then exercised until they became very, very hyperthermic, but not truly with heat stroke. So we were a little bit surprised out there that there's just absolutely no good comparative evidence in people with actual heat stroke, and that also there's no data about mortality with the different cooling rates. We know mostly from case series that the faster you cool somebody, the better off they're going to be. They're less chance of dying, less chance of end organ failure, brain damage, kidney, liver failure, and so forth, DIC. So we know just from those case series that cooling faster is better, getting somebody cooled down quickly. But these studies, all these comparative studies, don't really report on all of that, mainly because they're in healthy volunteers. There were just a few studies that looked at actual heat stroke victims. And then also, nobody looked at comparing different types of cooling. The first aid task force said that passive cooling does slow you, it's very slow. So it should be part of any strategy to cool somebody. But if you combine it potentially with other things and combine different active and passive cooling techniques, then you may be able to cool somebody very quickly. But surprisingly, nobody looked at combinations of cooling. So for that was probably the most surprising thing for me when we look at that particular review. Absolutely.
Another question is concerning the recovery position, of course, because if you are caring for someone with a suspected opioid overdose who is unresponsive but still breathing, would you put them into a recovery position?
That's a tough question. That's a very tough question, and I tell you why. First of all, if they're truly unresponsive with an opioid overdose, they are likely not breathing normally. And if they're unconscious, unresponsive, and not breathing normally, what do? We start.
Perhaps we do some thoracic pressure.
We begin resuscitation, right? Okay. We don't think about recovery position. It's time for resuscitation. So, and that's one of the reasons that we went ahead and changed the wording. What we're looking at are the people who have a diminished level of responsiveness. So maybe they're extremely intoxicated. Perhaps they took some benzodiazepine or some other medication that when you add it with alcohol, makes them not breathe as well and makes them lethargic, but not, if you were to shake them and yell at them, they're going to sort of reaction. And if they vomit while they're laying there, and I've seen this over and over again in the emergency department, they're laying there on their back and and then it comes up, and then they're breathing it in, they're aspirating, it's a mess. So that's the type of person, the scenario where a recovery position can help prevent that problem. And I think the wording of this question was just not great. So we've reworded it. We're going to look at it again. And I hope that answers the question.
Thank you, Nisi. Justin, on another question, because I think we have just 5 minutes more with Nisi.
Oh, did I go that fast?
We are perfectly on time. Really great for your speech.
What I do want to offer as well to the audience, and I don't believe I mentioned this at the beginning, but certainly if people have questions for any of our panelists related to first aid, related to any of the topics that are covered here, please put them in the chat. You can send them to us, and we'll make sure that we do our best to address those while we're here. So if anyone has any questions, please, like I said, put them in the chat. And we can actually come back to all 3 of our panelists here if we have a little bit of time in the end. Yeah, we're moving right along. So let me do this. I'm going to turn things over to David to talk a little bit more on the trauma side now of first aid. So Nisi covered a lot of the medical PICOs that the First Aid Task Force covered. David, I'm going to turn it over to you to share a little bit with us about some of the trauma-related PICOs that the First Aid Task Force looked at.
Yep, thank you very much, Justin. I'm just trying to get in to share my screen. If we get this right. Okay, here we go. Has that worked? You've got my screen.
No.
No?
No, we don't see your screen.
Oh, right. Hold on a second. Sorry.
Yeah.
Share screen. There we go.
That's worked.
That's worked. My apologies. The simplest things fool the old man of the day. So greetings to everybody, and thank you for spending a Friday evening with us. I'm here in outer space trying to avoid the COVID scare and seem to be surviving at the present time. And thank you to both Veer and Nisi for some excellent presentation just before. Can I just start by saying, and I think we'll all say the same as part of Nisi's task force on first aid, to thank her for the tremendous amount of work she's put into producing the published version of what you're hearing, the consensus on science published in the circulation and resuscitation a couple of days ago. And if you want any more details of what the medical and trauma first aid guidelines are all, not guidelines, sorry, COSTARs are all about, you need to go to there because all of it's there, all the references, etc. Just talking about references for a moment. So as part of the whole first aid, the task force actually read, and I'm not just saying they just selected, we selected some thousands of articles to look at, but they actually read some 275 articles which have been quoted in the COSTAR document. And just to put this into perspective, what I'm going to talk about now, trauma, basically, we actually reviewed 138 articles. That means read them, extract the data, do everything that Veer talked about in the first session here. So let's move into the session on trauma. And this is about trauma. From my presentation, which I hope you've seen beforehand, you'll recognize this slide. We looked at 8 trauma first aid questions, and you can see them here. I'm going to run through them very quickly in a little bit of a summary, basically. But just following on the references again, if you remember, I said 138 of those papers were reviewed for trauma. 67 of them formed the scientific background to the control of severe life-threatening external bleeding. And the ones in yellow here are the ones, if you remember, that I actually reviewed in the talk I gave pre-prepared, basically. So just looking at the control of life-threatening external bleeding, basically, let's have a quick run through what's actually or what we actually found. Pressure dressings, bandages, devices, proximal manual pressure. There isn't really nothing here that we didn't expect to find that wasn't there in the 2015 guidelines. We recommended that you use manual compression, and it's the simplest and easiest to do. You don't have to have any devices, you don't have to have any equipment. But if you then move on to hemostatic dressings, it could be stated that if you've got a hemostatic dressing, then direct pressure on the bleeding with a hemostatic dressing, or packing the hemostatic dressing into that bleeding, will actually improve the control. Moving to tourniquets, tourniquets have to be really available. Basically, you have to understand how they work. And how to apply them. And we did suggest that they be used where bleeding is amenable to be used by a tourniquet, to be controlled by a tourniquet, such as on limbs, etc. If a tourniquet is not immediately available, then you should go back towards hemostatic dressings and pressure dressings. One thing I did mean to say, and I do apologize. So if we go back, it's very rare, as Veer pointed out at the moment, that we actually get much evidence, and we got very little evidence even for all of these very, very commonly used procedures. But it was one of the very few strong recommendations that we had directly from the evidence, or that we had on pressure dressings, that it was a strong recommendation that we recommend that people use external compression to control bleeding, direct pressure. So moving back to tourniquets, and I'm sorry for that. Veer also mentioned, or she talked a bit about good practice statements. And we had two good practice statements within the tourniquet systematic review, basically. The first was that if a tourniquet isn't immediately available, that you go to direct manual pressure. And the second is that if direct manual pressure isn't working particularly well, or that you have a hemostatic dressing, that you should use that as well with the direct pressure, basically. It's interesting, these are good practice statements. There isn't any evidence out there for this, or it's very, very limited evidence. And for many of these, including especially the tourniquet, much of the evidence came from military use. And so it has to be questioned as to how this applies to the general public. We did suggest, and we do recommend basically, that people use manufactured tourniquets as opposed to those that are kind of improvised, and that we do recognize that the use of a tourniquet does require training and understanding to be able to apply it effectively. Let's move on to hemostatic devices. I did include a slide here because I wondered how many people knew what a hemostatic device actually looked like. And this was in the lecture as well. So the picture of the chap's trousers, etc., is the hemostatic device. It's a direct pressure device on the wound, basically. Not recommended, not particularly understood. There is very little evidence, comparative evidence, so that we're unable to recommend for or against the use of these junctional tourniquets by first aid providers. They are used by the military, but they're not used very often. Direct pressure, manual pressure is the preferred route. The other device is a clamp, basically a wound clamp. These have been out in the medical field for a little time now. We are unable to recommend for or against these again because there is very little comparative work. They're quite vicious looking devices, and they could be used for severe scalp injuries, and that's probably the only real indication for them if it's there. But there isn't any published evidence to support this at the present time. Let's move back to the real world. We actually did talk a little bit about pediatric tourniquets. We were concerned that the use of tourniquets, adult tourniquets in children, may not be effective because they've got smaller limbs. And we made a series of recommendations that, based on the early recognition of severe bleeding in children and the control of it, is essential. And that if direct pressure doesn't work and there is a tourniquet available, you may want to try this, but you have to understand that it may not work. The important point I'll go back to is there is absence of evidence of the effectiveness of tourniquets in children, and that you may have to revert to direct pressure to control bleeding in this age group. I'm going to skip simple stage concussion scoring, and I'm going to move directly onto the manual cervical spine stabilization, which was a scoping review. There were no studies identified that evaluated manual stabilization, and we recognized, the task force recognized as that the techniques for manual stabilization are skills that require education, training, and practice to perform. We also felt that in the opinion of the task force, and it was more of a good practice statement, that for patients who are not alert or awake, many benefit for gentle support of the head. The problem is that there is no scientific evidence to support how you would do this or which method you should use. So coming towards the end, we'll talk about superficial burns for a few seconds, if that's okay. So these are superficial thermal burns. We stayed with superficial thermal burns because these are the most commonly dealt with by first aiders, and we looked at specific dressings for these type of burns. There was concern about the failure to properly treat superficial burns, and we were not particularly this time looking at cooling. As Nisi's already said, this will be reviewed in a new scoping review, probably systematic review, as one of our topics for 2021-2022. We didn't identify any specific dressing for use in the first aid setting for superficial burns. And this was because most studies looked at the ongoing care of superficial, partial, or full thickness burns. Finally, in this, the task force agreed that the immediate effect and effective cooling of burns is still the primary intervention. As I've said already, we are going to look at that again and look at the timing and how that should be best done. I'm not going to say much about compression wrap, except because Veer's already talked a little bit about it, except to say that it's an interesting systematic review. It has been published and it's worth looking at. It was compression wrapped as practiced as a single intervention, as opposed to part of the RICE technique of rest, ice, compression, and elevation. And maybe this is the follow-up study that we need to look at as to the effectiveness of RICE as put into a first aid setting. So that is my summary of my summary, basically. And I look forward to your questions. And again, thank you to Justin and Pascal for chairing this session.
Well, David, thank you. Really appreciate that. And while you were chatting there, we did put up one of the questions specifically with regards to hemostatic. What do people have in their first aid kit, right? So is it hemostatic dressings, gauze, tourniquet, or tourniquet? Yeah. Both of the above or neither. So 11% are hemostatic dressings, 11% tourniquets. 76% of respondents had both of them. Both hemostatic dressings, gauze, and tourniquets. So a lot of people out there have several different options in first aid kits, and then 2% had neither. So really, really interesting results there with that. And I think Pascal asked Nisi a similar question and Vera about kind of the resources. And I wanted to explore that a little bit with you and the task force, the discussions that were had around recommending different devices and how did you take into account the different resources that might be available in different settings where they either may or may not be able to get hemostatic dressings, those sorts of things? How did the task force discuss and come to a resolution around the different resources that might be available?
So an interesting question, because I think in 2015, we had discussions in the task force and we tried to document these. In 2020, we started to use a lot more, a more standardized technique. We used evidence to decision tables. So these are series of questions directly asking the task force members to contribute as to their own experience and their own knowledge based on the science that has already been presented to them. And that includes a review of the equipment, the finances, for example, whether the country, as Pascal was saying, whether the country actually has the resources to actually be able to deliver some of the more advanced treatments that we've recommended, even down to hemostatic dressings or tourniquets. And it was quite interesting having had these discussions, how it varies across, not only across Europe, but across the world, basically. So I know that's rather a vague answer, but it shows that I'm quite pleasantly surprised that so many people had tourniquets and hemostatic dressings within their first aid kits. I must admit, if I go and buy a first aid kit off the shelf in the UK, it does not have hemostatic dressings or tourniquets in them. And I'm not certain that, and Pascal can correct me, I'm not certain that many standard first aid courses teach hemostatic dressings or tourniquets. So maybe this is something for the future. Maybe this is something which is the legacy of this meeting.
Very inspiring to think about that. That's great.
Can I ask Pascal, you from the Red Cross point of view, do you have tourniquets and do you have hemostatic dressing and tourniquet training within that, and NICI as well from Red Cross?
Yes. In fact, we have new first aid kits due to for example, the terrorist attack. It's very clear for Red Cross involved in Paris with the SAMU. It's very clear that now all the first aider and all the ambulances of the Red Cross has hemostatic and tourniquets, and with number of tourniquets, because effectively during the November, the event of November, you remember, it was the terrible aspect we had. We have not enough tourniquet to stop hemorrhage. So for sure, at this time we include in the basic first aid, including the lay people, we are teaching tourniquets. For the hemostatic is another thing, because I can say that for the majority of the country it's quite expensive, and this material is less used. But for sure, at this time we have manual compression, we have a compression bandage, we have tourniquet, and for sure hemostatic are less used. I don't know the situation in States.
Yeah, so great question. I think that for tourniquets, it's pretty much being pushed in all of the Red Cross courses, as well as in multiple other organizations are teaching Stop the Bleed courses, which is primarily how to properly apply a tourniquet. So tourniquets are being encouraged to be in all first aid kits everywhere you travel, in your cars, or even putting them in Stop the Bleed kits now. These little red boxes that have tourniquets, hemostatic dressings, and gloves. And they're putting them in public places next to the defibrillators, the public access defibrillators, or even in a box that has the defibrillators with it. So that it's easy access in airports. You'll see bleeding control kits pretty much everywhere. For hemostatic dressings, it's a little bit of a different story, but I think Red Cross is moving towards teaching hemostatic dressings, because basically to use a hemostatic dressing, you're applying pressure, and that's what you're doing for simple direct pressure. So if you can apply direct pressure with plain gauze, then you can apply hemostatic dressing in most cases. It's just you can't pack it inside of a wound in general without some training. So the hemostatic dressings are expensive. I looked them up in the United States just a few days ago, and I can buy a 4-foot long, 4-foot long length of Celox gauze, hemostatic gauze, for about $20. right now, which is not terrible because, I mean, you only need one, right? Generally speaking, in a first aid kit. And yes, it does expire if you don't use it, but I think it's worth $20 a year to have a hemostatic dressing in my first aid kit for where I travel. So yeah, so I believe in the hemostatic dressings being included, but I think that it does add to the price of the first aid kit, especially with tourniquets. And then the other question is going to be, what about children and tourniquets for children? As David said, it may be that there are specific tourniquets that work on small children and infants that don't work and others that don't work on them. So it may be that we have to carry more than one tourniquet potentially. We don't know yet, but for right now, I think having just a regular tourniquet, such a windlass one with the rod that you turn in your first aid kit, is very important. So thank you.
And from a practical point of view, something I said yesterday when we talked about the guideline, and it's in the guideline, is once you've got a tourniquet applied, you should basically, it's quite painful to apply it to the level of pressure you'll need to stop the bleeding. So you shouldn't be put off by that. And the second thing is, once it's applied, you should note the time on it, but you should never release it. That should only be done by a healthcare professional in hospital when they've got full facilities to control any bleeding, basically. There are some guidelines out there on the internet which actually says you put the tourniquet on and release it every 10 minutes just to check whether there's still bleeding. That is a disaster, because once you release it, you'll never get the pressure back on because the tissues will have seized and you'll never be able to apply that pressure again. But I'll hand back to the chairs because I've said enough, and I know we've just got about 5 minutes left.
Now, all really good points, and it especially with the global burden of disease, when we talk about trauma and hemorrhage control, this is a really important question. And so addressing kind of what are some of the ideal ways to help manage severe life-threatening bleeding is critical to really improving mortality and morbidity from trauma because of as I mentioned, the global burden of disease. David, as you mentioned, we have a few minutes left. Again, if anyone has any other questions, please put them in the chat. And I wanted to give our panelists, if there was anything else that you wanted to touch on, again, we have just a few minutes left. Anything else that you wanted to touch on before we go? I will open it up. David, Nisi, Veer, if you have anything else that you wanted to cover before we end this session.
I think just one point for me, and that is going back to hemostatic dressings. A study was done last year, 2019, that was a randomized controlled study looking at lay provider use of hemostatic dressings. And there were 330 participants. They looked at S-folded and Z-folded gauze. They looked at plain gauze. They looked at injectable mini sponges, and basically found that with a very short introduction on how to use them on an iPad, and then one very brief 5-minute hands-on skill session, that the lay providers were all able to use them, but especially the injectable mini sponges. So it's basically just showed that if you can apply gauze and pressure, then you can go ahead and apply a hemostatic dressing.
So just while we're talking about dressings, very quickly at the end, let's put an advert in for cling wrap, basically, because you can use it for superficial burns, and you can also use it to store your avulsed tooth, actually. And as Vera said, everybody seems to have that in their cupboard somewhere. So it's a first aid treatment which is universally available. Wonderful.
Well, with that helpful tip of something that all of us can kind of take home and put in, or take from our home and put it into our first aid kit. I want to thank, on behalf of Pascal and myself, I really want to thank the three of you, our panelists, for being on here, for sharing your time, sharing your expertise. Vera, Nisi, David, thank you so much. Thank you for everything that you've done with the task force, the monumental work in putting all of this together and having that recognized by being published in Circulation and Resuscitation earlier this week. So thank you very much to the three of you. Thank you, Pascal, for helping me to moderate this session. And I appreciate everyone joining us for this. Thank you very much. Take care and have a great weekend.
Thank you, Justin, and thank you, Pascal. Thank you, Vera and David.
Thank you.
Thank you all.